Good morning. Thank you, Anna. Actually, I'll update your comment in the chat. Welcome to everyone. This is equity webinar number 7, actually, equity teaming. And it's our second conversation on equity teaming. I want to say thank you all for those of you who were able to make our summit this past week on April 12th. And for those of you who were able to attend today, we know it's spring break and we know we just recently had a summit, though we are still very excited to continue to bring our monthly webinars for our Penguin Maternal Equity Bundle. All right, we'll go to the next slide. So as usual, please type in your name and institution into the chat. That's one way that we take roll. Keep yourself muted when you're not speaking, and I'll do the same, but feel free to raise your hand or type questions into the chat. And then when we have our discussion time, you can feel free to unmute to ask your question after your hand's been raised. We do record each of these sessions, and those recordings are uploaded to our webpage, and you can get CME and CEU credits for attending these webinars. So thank you for those who are putting in their names into the chat. All right, we'll go to the next slide. I wanted to call attention to a couple of upcoming events before we get started, simply because they're very important, and because we want to make sure we don't miss them, because a lot of our webinars end so close to the very end when people need to hop off. We have our free Speak Up Champions racial bias education available on May 3rd and May 10th. And those are 2 4-hour virtual sessions. Continuing education credits are available. Here is a QR code for registration. We also have a link for registration. You can also find that on the website for the Institute for Perinatal Quality Improvement. So we look forward to increasing our registration for another Speak Up Champions course. So recall, this is one of our bundle process measures. So if you would like to increase the number of faculty and staff at your institution who've been trained in racial bias education, please register for Speak Up May 3rd and May 10th. Right, go to the next slide. We also, the next step in the path of Speak Up from champion becomes ambassador. And so we have a free Speak Up Ambassador implicit and explicit racial bias education training on April 27th, and we have another on May 25th. Also, there are CE credits for that. Here are the QR codes. You can also find those on the Institute for Perinatal Quality Improvement webpage. But the prerequisite is that you have to be a champion to then train to be an ambassador, and then you become faculty after that. So if you are champions, congratulations and thank you. There are also opportunities to now become an ambassador on April 27th or May 25th. Next slide. And thank you. Anna has put those in the chat as well. So welcome. For those of you who've just gotten on the Zoom, please put your name and institution into the chat so that we can take attendance and roll. We're going to go into our data review as usual, and then we have a very special guest, Dr. Rose Molina from the Beth Israel Deaconess Medical Center, who'll talk about their equity team. We'll do a little bit of QI teaching. I think we're going to make it this time. Oftentimes we have just such a robust discussion from our speakers that it's fine. We have our QI teaching available in a toolkit. We also will have some videos, if we don't already have them, posted on our webpage with QI teaching, but it's just nice to be able to go over some teaching at each webinar. Wonderfully, we just had our summit and Dr. Christina Davidson presented her data, and here we can use the concepts of real data run charts to look at what she also presented to have a QI teaching on run charts. And then we'll have wrap up and announcements. All right, next page, or next slide, sorry. As always, thank you to our wonderful QI group for the Maternal Equity Bundle. This is a multidisciplinary broad group that is still always open to others who may want to join. This is the group that helps us to think about how the bundle is being implemented, and any support that you may need through coaching calls. We have support with a broad range of expertise on this work group. So if you'd like to join, please let us know. Next slide. And thank you to the participating hospitals. So here is the graphic we show every month. We can still see that most of our hospitals participating of the 22 are toward the east. So I'm always excited and thankful for those in the south, the middle of the state, and then going out toward the west. If you have colleagues or partner hospitals that are in the south, middle of the state or toward the west, please let us know. We can help to bring more on board. Thanks for the 22 hospitals that are participating. All right, we'll go to the next slide. As usual, the AIM bundle measures are due to the Betsy Lehman Center's REDCap link between the 1st and 10th of each month. So given that this month is April, we will ask that your information is submitted to us by the 10th of the month as we had, and that represents what happens in March. So when we show the data today, you'll see data from when we launched in September through March. It assesses your structure and process measures. Recall, your outcome measures are always presented for you or provided for you by the Betsy Lehman Center, and all hospitals that submit data have a memorandum of understanding. All right, we'll go to the next slide. I wanted to point out and highlight, and thanks to Kaylee and Claire for the wonderful graphic, we have a new radio button that many of you may have already seen, but if you have not seen, this is a question that says, do you have the data to complete this process measure? If you select no, it allows you to advance through the REDCap survey to the next question. So that hopefully helps a lot of folks that may not have the data in that moment. You can always go back and answer questions. If you have difficulty with that, you can email us and we can get you links to go back to answer other questions. But if you'd like to move through your surveys with data, or to get to a question where you don't have data for one, we do have this question available. All right, we'll go to the next slide. And we'll do our data review. So let's take a look at our structure measures. We've still been focusing in on the structure measures, mostly because many teams are still there working to increase their structure measure accomplishments. And then once those are accomplished, we don't really come back to the structure measures as much. We go into the process measures. So of our structure measures, do you have an equity team? Have you communicated your equity goals through an anti-racism statement, change concepts, or a SMART goal? In September, we had 42% who said, yeah, we have an equity team of the 12 hospitals participating or submitting data at the time. Of that, 11 of the 12 that have submitted data through March, 64%. So we have increased the number who have formed their formal equity teams, which is terrific. We also have the goal of having those equity teams be very diverse, meaning having community members, diversity of roles, and diversity by race, ethnicity. We see that diversity of roles and by race, ethnicity has increased. And we know that we have teams who worked on engaging a patient. We know that that's a challenge. We also have brought some additional resources to support the teams as you want to bring on community members. We know there are challenges to how do we have folks involved in our everyday, day-to-day workflow when they may not be employees of that hospital, et cetera. And so we've worked also with the Colorado PQC, because they've got a really robust system on bringing on community members to their equity teams or to bring into the work. And so if you're having a challenge with that, don't hesitate to reach out to us. We can do a coaching call and support you in that effort. We've also seen around a stable number of those with anti-racism statements, but those who've determined to have change concepts and SMART goals or aims, we've seen an increase there, which is terrific. So we'll start to work with some of the teams here forward on asking what are your SMARTY goals and what is your aim statement and what are your change concepts so we can understand what teams are working on. All right, we'll go to the next slide. Also, we asked, do you collect data? And with that data collection, do you collect it for race, ethnicity, and language through self-report? And then do you stratify your data there? Data collection for all of these demographics is around 90%. If you see all the way to March, that's the first box is 90%, and then every third box is around 90%. In terms of self-report, 100% are saying that these are by self-report. Stratification, not all the time, but nearly half the time we're stratifying data by race, ethnicity, and language. All right, we'll go to the next slide. Also, looking at our PREM. So one of our structure measures is having a PREM implemented and available at your institution. Now, we haven't gone as far as to say, what do those PREM outcomes look like, and what's happening in terms of an outcome measure in terms of PREM. What we're seeing, though, is more are moving toward that blue is increasing, having a fully in place PREM at their hospital system. And if you go to the next slide, we can see what those are. And we're so excited to see that as a March, many of the PREM that's implemented is because of team birth. So congratulations to all the team birth teams that are moving forward as well. But as always, we see that HCAPS, Press Ganey, NRC, Qualtrics, or Qualtrics is probably someone's own personal PREM. But what's more important is that we're actually starting to look a lot more often at what is the patient's experience of labor and birth at your hospital system. All right, we'll go to the next slide. Without further ado, I'd love to introduce my colleague, Dr. Rose Molina, who will talk about what's happening at the Beth Israel Deaconess Medical Center. Rose at BI is a champion of birth equity and health equity in many different ways. And I'm really excited to see all the structures that they've put in place at the BI. They've had a lot of new leadership within that institution, and to learn and understand what some of the facilitators and barriers are to moving equity work through the BI. So I'll turn the microphone over to you, Rose.
Thanks so much, Audra, for inviting me to share today. I will say that I am actually coming to share truly an update as to where we are. And I honestly will be sharing the questions that we are actively working through, and would love to hear actually from you all and kind of flip the script a little bit to hear if you all have struggled with similar questions, and if so, how you all have overcome them or discussed them or are working towards similar, addressing similar challenges in your institutions. So with that, why don't we get started? Perfect. So the first thing I just wanted to mention is simply our internal context at the BI. We've had multiple leadership and staff changes over the past 6 months, which in any institution can cause some sort of short-term challenges in terms of navigating. So that's one thing that's been happening in the background with regard to our departmental leadership, our division level leadership, as well as staff that directly work on equity focused work, particularly related to the Penguin Equity Bundle. So that's just an important background to know. Additionally, we have had some urgent operational and clinical challenges that have just simply needed to be addressed and have taken priority over implementing some of the quality improvement projects that we had planned over the past 6 months. And so that is just a little bit of our background in terms of where we're thinking and sort of what else has been going on in our department that we just have to attend to at the same time as trying to focus on a lot of the important equity and quality improvement projects related to this bundle. We can go to the next slide. So some fundamental questions that we have struggled with over the past 6 months are these. And so I would encourage you all to think about these if any of these relate to your departments or institutions. And again, would love to leave some time at the end to hear from you all about how you think about these as well. So first is really thinking about how do we integrate diversity, equity, inclusion, and advocacy throughout our department, especially when there are multiple efforts or initiatives that overlap but are not always coordinated. So this bundle is an amazing opportunity for us to focus very concretely on a set of components, specifically around birth equity. However, we have really thought about, well, what does this really mean in the context of our OBGYN department? How does this, how do we think about our DEI goals broadly, given the range of patients and the range of workforce that we have, and not necessarily exclusively around pregnancy and childbirth? Additionally, we have multiple groups within our department that are working towards DEI goals, and some of them are related to quality improvement, some of them are related to research, some of them are related to advocacy. And so how do we bring together everybody who is working towards these very larger, the bigger picture goals around diversity, equity, inclusion? How do we coordinate together so that we are not duplicating efforts, that we're coordinated, that we're synergistic? And so that's something that we have been really thinking about deeply within these past 6 months, given some of the leadership changes, and as well as how we can make progress on this equity bundle in the context of everything else that we're doing as a department in these areas. Following that large question is what infrastructure is really needed, and with that, what additional financial support is needed. One of the things that we have encountered is that a lot of the DEI work in our department has been ongoing because individuals are very committed to getting that work done, but we don't always have a clear infrastructure for sustaining the work past specific kind of small scale projects. And so as we think about this equity bundle, it's an opportunity for us to think more broadly about, well, what infrastructure do we need as a department? What financial support do we need as a department to be able to take on something like this equity bundle across the department? Lastly, our last fundamental question is really prioritizing short-term work goals versus long-term vision. So this is simply because, as I mentioned, we have had several leadership changes. We're going through a strategic planning process as a department, and building out what the long-term goal is for diversity, equity, inclusion, and advocacy simply takes time, takes months to develop that. And so in the short run, when we have kind of a year to think through this Penguin bundle implementation, how do we sort of prioritize our short-term work versus our long-term vision and make sure that we're making progress incrementally, but we're also building towards something that can be sustained over a longer period of time. We can go to the next slide. So I know I was asked to talk a little bit about our equity team, and so I will present a brief update about that. Here is a picture of those individuals who have come forward as being part of our equity team. We have great representation from physicians, nurses, administrative staff, researchers. We are still working on engaging a patient in our equity team, and that's actually one of our areas that I'd love to bring to you all today. So why don't we move to the next slide? Our institution has spent actually a couple of years now really trying to develop an equitable process for engaging patients in the work that we do as a department, not specific to the Penguin bundle, but again, more broadly as a department. And we came to the realization that our hospital, like all hospitals, have PFACs, Patient Family Advisory Councils, but those PFACs are often not truly representative of all the diversity of the patients that we see, certainly not in our OBGYN department. And what we really wanted to do was to develop a patient advisory team where we could engage with patients and really partner with them in all of the quality work that we do. So from quality assurance review committees to quality improvement initiatives, of which the Penguin Equity Bundle is one, we wanted to have a structure in place for how do we really partner with patients in an equitable and intentional way. And so over the past few years, this work has really been led by Chloe Zira and Alicia Larson and Bola Bukoye, who no longer moved on. She was working at the BI just until last year, but is no longer with us when moved back to Texas. And so the three of them, along with Martina Dayhill, really started to put together a lot of the groundwork for how do we really engage patients in our work as a department. And a lot of it actually came down to some infrastructural nuts and bolts. Well, how do we even compensate patients for their time? We recognize that that is a value that is important to us, that we want to recognize people for their time and expertise. And so we actually had to go through a process of figuring out, well, how can we pay them? That was not actually a simple, straightforward. There was no straightforward answer to that, and required a long list of meetings with a long list of individuals to figure out how can we actually institutionalize a process for this. So this has been going on in the background, but we are in the process of trying to identify at least a few patients who would be able to work with us, particularly on our equity team for this bundle. Next slide. This is really just a summary of what the patient advisory team is in terms of what the objectives are, who our ideal candidates are. And again, just the emphasis that this is broader than just the bundle, that this would actually, originally, this was actually a vision that we had for inclusion in our department, more broadly around QI initiatives, QA review, and then of course, using this infrastructure for the Penguin Equity Bundle as well. Some of the roadblocks, as I mentioned, some of them I mentioned, was the reimbursement structure. Other roadblocks is actually identifying someone who would want to engage in this type of work, ideally over the course of some substantial amount of time, not kind of short one-off meetings, but would actually be a partner with us over months and even years. And then, of course, as I mentioned, we had some staff turnover over the past year, honestly. And so we've just been having to navigate how do we keep this work moving when we have turnover of staff and competing priorities. Next slide. So key questions that came up around patient engagement. Again, would love to engage with you all in discussion around these as well. So some of our reflections are, well, really who's at the table? And so that was one of the driving reasons why we felt like we needed to create a distinct infrastructure for our department, separate from sort of the hospital PFAC, because we didn't feel like the patients who we were caring for were really, their voices were not represented in those spaces. So we wanted to think critically about who's there. Our second question is, what does meaningful engagement really look like? How do we really build true, authentic kind of partnerships with patients? And how do we want that really to work? How do we want to avoid tokenism, recognizing that no one individual can really represent a large group or community? So how can we structure the space so that it doesn't place a burden on people and feel as if it is an experience around tokenism, which is not our goal, but can sometimes be a byproduct if we don't create sort of the system and the space correctly. The fourth question is the one that I mentioned around how do we appropriately acknowledge and compensate patients as experts, especially when the desired individuals may have the least ability to participate. So one of our struggles, aside from dealing with kind of like the administrative red tape of how do we compensate patients, is how do we really ensure that the voices that we want to be sure are included are actually included when those individuals often experience, like in some ways, the worst or most egregious forms of racism and other forms of oppression, and may have the least ability and least flexibility and least time available to actually participate in these types of projects. So how do we think about that? The next question is, how do we identify and recruit people for this role? So recognizing that we're hoping for long-term partnerships and not short-term kind of consulting. How do we really develop those types of relationships over the long term and really identify folks who are interested in partnering with us across a variety of potential projects? Of course, some people might have very specific interests in one specific topic or area, but then how do we identify a team of people or a cadre of different people who might be able to engage in different parts of our work? And then lastly, is a question very close to my heart, is how do we engage across language barriers? So one of the things that became overtly obvious was that we are only doing this recruitment in English, which is the reality I imagine in most places, that it's been very hard to identify best practices for truly engaging people across language differences. But simply naming that we are systematically excluding a large number of our patients, up to 10% of our patients, if we don't allow for other languages to be represented when we develop these types of teams. Next slide. So in the past few months, we had an opportunity to work with some HMS students around doing a very kind of short needs assessment. So there were 5 Harvard Medical students who joined us in January for their health system science course practicum. And in that course, they learned a lot about quality improvement processes and tools. And so this was really an opportunity for them to delve deeper into a specific quality improvement initiative to kind of learn some of those strategies and tools with a real kind of life case scenario. So we recognize that our equity team was not as representative as we would like it to be across the department. So while we have wonderful representation from clinicians and nurses and administrative staff, we realized we're missing medical assistants, we're missing some of the inpatient postpartum nurses. We had nice representation from L&D nurses, some representation from outpatient nurses, but just thinking like very broadly across our department, we noticed that there were some missing voices. So we thought that this was an opportunity for students to help us understand what are the perspectives across our department, not just of those people who have come forward who wanted to be part of the equity team. So with that, you can go to the next slide, Claire. They did a very short project with us over the course of a month where they actually spoke to 15 individuals. As you can see here on the right, they did 9 semi-structured interviews and then 1 focus group of 6 individuals. And they really had the intention of trying to understand and hear from people who are not part of our equity team and who are not involved in quality improvement work and equity work in our department, because we really wanted to make sure that their perspectives were taken into consideration around what should we prioritize within that Penguin equity bundle to work on now versus later. So given the background context that we have, we've had some other competing priorities over the past 6 months, like how do we prioritize, well, which part of the bundle do we want to focus on like now versus later? And so this was a project that was really helpful to gain insight across the department around what people think is important for us to prioritize. The 3 things that came forward from those interviews is on the bottom left with some illustrative quotes in the box. People felt like we should really be focusing on building better partnerships with our community members. There was some consensus around enhancing staff education and expansion of patient-centered services. The majority of those comments were around language access for our patients who speak languages other than English. And then one of the questions that the students asked the group was their thoughts about the anti-racism statement. So we, as our diversity, equity, inclusion, and advocacy committee, had created years ago a welcome sign around kind of the values of our department in those areas. And anti-racism was implied but not explicitly named. And so one of the questions we had the students ask the group of people that they interviewed was, what do they want to see us as a department put in an anti-racism statement? And impressively, the majority of people, first of all, felt like this is super important work. It needs to be intentionally named outside of sort of the welcoming value sign that we already have. But there were a lot of questions about holding ourselves accountable to what we write as an anti-racism statement. How do we collect data that's consistent with an anti-racism statement? And how do we actually ensure that our department takes action on what we write as an anti-racism statement? So a lot of this was really important food for thought as we begin to think about what do we prioritize in the upcoming months. Next slide, please. So again, more key questions came up. So some of these I just mentioned. How do we hold ourselves accountable to what we write as an anti-racism statement? Again, whose voices are not at the table and who do we need to include and how? How do we advocate for systems change, not knowing the financial context and long-term return on investment? And lastly, how do we balance the urgency and need to make immediate changes with the desire to do things right and sustainably? So thinking about like, do we do something quick and fast now to get some sort of like, you know, low-hanging fruit, immediate wins? And how do we balance that with like the longer term vision and trying to do things right and sustainably? Next slide. The last sort of area that I'll present before opening it up to you all for discussion is where we're at in thinking about the PREM, sort of the PREM measure. And again, our department had actually previously launched this question that I pasted here on the slide, which is a QR-based code that we've translated into the top 5 languages. And I'll just read it out loud. So this was a previous implementation before the equity bundle was started to be implemented within the past year. It's a sign that has been posted on the postpartum units that says, we care about your experience at BIDMC and aim to deliver respectful, affirming, and anti-racist care. If we did not meet this standard, please share your story. The OB-GYN department is asking patients for feedback to help us improve the care that we provide. Giving feedback is completely optional, and feedback is anonymous unless you choose to leave your contact information. If you would like to discuss your experience with the patient's relations team at BIDMC, you can call this number or email this email. What are we doing well, and how can we improve? So this is what we launched back in 2020 to 2021. And it was a soft launch. We haven't gone sort of full court press on implementation of it. We soft launched it on the postpartum units. We've received a few responses, but have not received a huge amount given that we haven't done any implementation training around it. We just kind of started to post it to see what we might get. As you can imagine, this is a very open-ended qualitative question, and so it doesn't lend itself as well for long-term measurement and benchmarking like other PREM instruments that you all may have described in the past or shared in the past that I'm sure some of your institutions might be using. However, when we designed this question, this was the information that we really wanted to know. We wanted to hear the stories, and we wanted to hear how patients think we can do better. And so it's slightly different. It's a different type of question. It gives us different type of data. It's not useful for long-term benchmarking, but it raised, again, more key questions for us. Are these the right questions that we should be scaling? How do we ensure that we hear experiences from minoritized individuals who may not see the sign and may not feel comfortable coming forward? And so we've had a lot of discussions about what is the right PREM for us to implement. Do we implement something that is trackable and comparable across time and institutions? I've had some conversations with some of our researchers as well around validation of questions, especially if we'll be scaling it and tracking it over time, ensuring that questions are actually validated, particularly for a diverse population with variation in terms of health literacy and understanding. And then, of course, the issue of making sure that they're translated and accessible to people across languages and also communication needs and preferences. So perhaps we thought about not all people would feel comfortable typing out a response. So could we provide an opportunity for people to leave a message to share their story or talk through something instead of having to type out something long? So just being sensitive about inclusion as we think about whatever PREM we decide to roll out. Next slide. At the same time, there were several people in our department, including myself, who are particularly interested in PREMs and measurement issues. And so I am currently on a K-12, and I'm focusing on how do we measure and how do we enhance trust during pregnancy care, specifically for Spanish-speaking patients. And so again, just thinking very intentionally about language barriers and how 10% or more of our population is systematically excluded unless we account intentionally for language barriers. And then secondly, as we think about PREMs, like what is the role of trust and how do we identify what the drivers are and the levers of change are for actually building trust? And what are the actual experience outcomes that matter to patients? And what are the experience outcomes that we can learn about in terms of how do we improve them? So it's one thing to measure them, but if we don't know anything about how to improve them, then it seems like that's not as useful of a pursuit. So really trying to thinking about how do we unpack what are the drivers and factors that facilitate trust, what are the drivers and factors that destroy trust, and how can we create solutions that really enhance trust appropriately for our patients and for our staff. The second area of research of interest in our department is what are the optimal implementation strategies, including the modes of dissemination of PREMs and PROMs in pregnancy care. So really thinking critically about how we collect data is just as important as what we collect. So a lot of the focus is on, well, what measure are we going to use? What are we going to measure? What are the outcomes? How is it worded? What are the items? But at the same time, I think we're really interested in, well, what are the ways in which we should collect the data? Do we collect it in pregnancy care? Do we collect it in the labor and delivery room? Do we collect it on the postpartum unit? Do we do it in writing? Do we do it as audio? Do we do it as text message? Like, what are the different modalities and implementation strategies for PREMs to really be effective in terms of gathering information from the diversity of patients that we see, and not just one specific subset of patients, which historically has been what we've seen. Most of the experience types of surveys or questionnaires that we have in our department tend to be filled out by a specific subset of patients that respond to those types of things. And that might be a product of the way that those questionnaires are delivered, whether it's by email, by phone, by letter, all of those things. And so we have very little guidance on, well, what is the best way to really reach the broad diversity of patients who we hope to hear from in implementing a PREM. So with all that, I think you go to one, I think I have one more slide perhaps. Yes. I think my closing thought, based on reflecting on where we are in navigating this bundle implementation, is really thinking about the process for implementation is just as important as the outcome. So yes, of course, the outcome is to enhance equity across birthing individuals, but I think the process by which we implement the bundle matters incredibly. And so we've actually spent a lot of time thinking about our process because we're really trying to focus on using this bundle to build something broader that can be translated into different quality improvement initiatives across our department. Similarly, how we do the work matters, and not just what we work towards. So it's really just another way of saying the same thing, that being inclusive in our process, being intentional in our reflection as a team in terms of where we are, where our biases are, where our blind spots are, is really important. And so how we do the work matters, and not just the fact that we're working towards improving equity around childbirth, but that we are intentionally engaging with each other in a way that also promotes equity within our team. So with that, I'll end. I hope we have time for questions. I would love to hear from you all. If you all have struggled with similar things, if you have any thoughts about some of the questions that I posed earlier. This is just a quick update as to where we are from BIDMC.
Terrific. Thank you, Rose. We do have one question in the chat, and I think this is maybe a question for us all, is how do you deal with the HIPAA compliance, when you are involving patients on your team?
Yes, that was part of the long process. So I think, I don't know if Alicia or Martina are here, so they can correct me if I misspeak, but there is definitely a process for that. So basically, any patient who gets onboarded to our patient advisory team needs to go through like an onboarding orientation process, which includes HIPAA training and signing off on confidentiality, just like any other, essentially like a volunteer in the hospital, just like volunteers at the hospital have to go through kind of that basic stuff. The same thing would apply for patients or community members who join us in that way.
Are there other questions for Dr. Molina, for those who may want to raise their hand or even unmute and ask your question, or put your question in the chat?
Hi, I'm Dr. Molina. I'm Shaniqua Choice, a community member. I think I just want to recap before I ask my question to make sure that I understand like the purpose and objective of your presentation. So what I saw was that BI committed to the equity work and the bundle, and what happened was you ended up with more questions than solutions is kind of like where your organization ended up, just to be really clear. So with each step that you took, essentially every effort that you made in order to try to reach your QI goals as an organization, you weren't really able to come up with more data-based or data track solutions because there were more questions that came up every attempt. Is that a good understanding?
Certainly the first part. So it definitely led to a host of additional questions that we are working through. In terms of the data collection, though, I know Martina submits our data monthly. And so we definitely, a lot of the data stuff we have already implemented. So we do collect real data, we do disaggregate by real data. So that part of the Penguin bundle is certainly underway. But really some of those other components, the ones that I presented today, that's really where we're at with it in terms of we're thinking through it. We have questions come up. We're trying to navigate how do we move forward. And so we don't yet have data around the PREM because we're still figuring out which PREM we'll be implementing. Our equity team is the team that I shared, but we're still actively working towards including a patient or community member in that team. And then the anti-racism statement has not yet been written. We have been waiting to hear about departmental leadership changes around whether that needs to be part of our larger departmental strategic plan, and whose input we need to guide that. So that all of those things are still in process, but in terms of the actual data, we are collecting data and we're submitting that on a monthly basis. I hope that helps clarify where we're at with that.
Yeah, that I just wanted to make sure that I understood before I had asked the question. Thank you for that.
Lots of praise in the chat, Dr. Molina, to comment that your conversation was really thoughtful and thorough with some of the same challenges others have identified, and there's still yet more to consider, as you said. Marianne Bamba has her hand raised. Marianne, do you want to unmute and ask your question?
Yeah, thank you so much for your presentation. And you had mentioned about integration and avoidance of duplicative work earlier on in the presentation, especially in light of all the, in light of change and, financial and staffing pressures, et cetera. So I'm just wondering, what are your thoughts on patient family advocacy council work being done at an organization level versus departmental? Would that be better? Would that avoid duplicate work being done, allow for better communications across the continuum of care in the hospital? What are your thoughts? Thank you, Dr. Molina.
Sure. My personal thought is that I do think that it would be helpful to have a team at the departmental level, because I think that specific issues and projects at the departmental level will differ, which means that the patients who we hope to partner with will also be very specific. Like for our department, we definitely want to include people who have given birth at the BI recently, or are pregnant recently, or pregnant currently, for example. And so those individuals might not be included in the broader institutional PFAC. However, I'm sure the broader institutional PFAC will have kind of a more, I imagine, I hope, like a more life-based approach, maybe people across ages, across genders, across, different experiences in the healthcare system. But I think specifically for this, even for this very specific Penguin Equity bundle, I think we're really interested in hearing from people who have lived experience of pregnancy, either have been pregnant, will be pregnant, are planning pregnancy, like some connection to pregnancy, because we think that that perspective is fundamental for our work. So in this case, I do think that having a departmental structure would be the most effective. Not to say that the broader institutional one, certainly needs to also be there, but I think what we're looking to do is a little bit more than sort of a consultative group. Like, I think that's the other piece of it, is this a true partnership? What does a true partnership look like with patients and community members? How do we work together and really co-design projects versus it being a consultative group that, we may go to for input or feedback about something, but really trying to go at a deeper level of like real co-design, co-development of work together, as opposed to it being a little bit more unidirectional than bidirectional.
Thank you.
Now that If it's all right, if I jump back in and ask my question, I just was like trying to summarize. Okay, so I think what I kept hearing you repeat was, how are we going to get access to those patients in their language and in a way that feels accessible to them? Is that like one of the repeated issues? I think one of the other, I think this is probably more of a question as well. In my school, one of the issues that we ran into is that we were giving access to the information and in the proper language, but not at the right reading level. On average, our parents have like a 5th grade reading level in English. And so I feel like I always like to mention that as well, when it comes to getting access to people who are speaking in another language. In terms of that, is it possible, aside from the QR code poster, outside of having a student-facing population, it seemed based on that data that people felt really comfortable speaking to those students, maybe because of their age, or maybe because of maybe there seemed like a lack of power in that. Are there more opportunities to talk to patients in a way that kind of reduces the power in the dynamic?
It's a great question and a really important point about power dynamics. And it's honestly something that I struggle with all the time in my own research. So thinking about, because I'm focused very specifically on Spanish-speaking individuals, I very much hesitate and question whether I can personally reach out to my own patients to engage in some of this work, because I feel like there is a power dynamic there that would be unfair for me to, as their physician, ask them to do something that's outside of the scope of their clinical care as a patient. And so I refrained from doing that with a very few exceptions. And I think that it is something, it's another great question that I think that we're struggling with, is like, how do we navigate what are the known power dynamics if it's a physician approaching a patient or a nurse approaching a patient that they might have a relationship with from clinical care? And how do we think about strategies that ameliorate those types of power dynamics? And in my own work, one thing that I've been working towards is really developing a multilingual team of, as you said, I think that students are more approachable. I think that there tends to be a little bit less of a power dynamic. Of course, whenever a university institution might be mentioned, there's like maybe some degree of a power dynamic introduced, but I think emphasizing the student role tends to improve that a little bit and make it a little bit more level of a discussion, as opposed to it feeling like there is an overt power dynamic there. So I think I do think that having students as part of the team is helpful for that. I think also engaging with people across the healthcare team would be helpful. So one thing that we've talked about is really engaging our medical assistants, for example. So I work at DIC, and our medical assistants are truly from the community, that questions about how do we bring our medical assistants into the team, because there's probably the least differential in terms of a power dynamic between the medical assistants and our patients, because they're literally from the same community, at least where I work. And so I think just being, again, expansive in how we think about our team. Yes, students are great, are wonderful assets, but I also think that, thinking about even within our team, that we can work towards being intentional about overcoming power dynamics by thinking about who is on our team. And one example is thinking about medical assistants, thinking about the people at the front desk. At DIMIC, we call them PACs, patient assistant coordinators. And so thinking about those individuals who are also part of our team, but may not be intentionally thought of as part of our team traditionally because of power dynamics, honestly. And so I think that's a great point that we can all think through in our own institutions.
Thank you so much, Rose. This is terrific. More work to be done, correct? More to come. Claire, if you want to put the slides back up, we'll move into the next segment. We will always have Dr. Molina is nearby and near and dear. So if there are additional questions or thoughts, definitely happy to have you back, Rose, to come and talk more about where you guys have landed in terms of bringing additional voices to the table, because I think that, to your point also, Shaniqua, how we're doing that, we're usually within the same vein of where we've been, and we need to start thinking differently and thinking outside the box, and how we collect information and engage with folks. I really want to just uplift again the point you made, though, also around, having diversity on our equity teams, and similar for the equity team that we have here in San Diego, we're in English. And so if we're talking about language barriers, knowing that, we are limited to support and voices from patients who only also speak English, lets us know the inherent inequities we already have in our structures. So something for us to all keep in mind. Well, we'll take a moment, just a few minutes then to go through a real data review and run charts, this case example from Texas. So without further ado, if we go to the next slide, Claire. Wanted to call attention again to our speaker for our summit, Dr. Christina Davidson from Baylor College of Medicine and Texas Children's Medical Center. They had their publication in April of 2022, examining the effect of quality improvement initiatives on decreasing racial disparities in maternal morbidity. If you go to the next slide. One thing we really wanted to call attention to is what is in this publication, and we'll show a graphic that she showed during the webinar. I'm sorry, not during the webinar, during the summit, on a common QI measurement strategy, and that is a run chart. When we put in place our initiatives, what we're looking for is for the change to happen and for those changes to become improvements. And when you're looking at data, you want to be able to show and see that your data shows that there is a variation or something that's very different, something that's not expected or inherent or an inherent part of your process, but something that's not inherent, something that has actually shown that it's leading to a change. So that does not mean one data point. At times we'll see people look at one or two data points and say, we're going in the right direction. And that could still be true, but it's too premature and too early to give to qualify that with just a few data points. So we'll look at run charts for just a moment. Control charts are like run charts, but with your control limits, top and bottom. Run charts, if you go to the next slide, give us some information to help us determine whether or not our changes have led to an improvement. Similar to the run charts, we have control charts. Control charts usually come later, though. Control charts come after you've had enough data points where you can establish your upper and lower limit of control. Some do just create control charts up front and create an upper and lower limit depending on what kind of process they're looking at. Back in my Exelon days, I do know that we used a lot of control charts because we knew what our limits were based on the actual chemical structures. But when you're thinking about process improvement or change, typically one would allow run charts to go a certain amount of time. And then from that and from the data they have, they would determine what would become their upper and lower limits. All right, we'll go to the next slide. And so here it is. Here is one of the figures from her publication and with her team. And this is looking at the rates of SMM from hemorrhage among non-Hispanic Black mothers. And this is where they showed, if you see the median, and they've actually done a great job identifying and labeling where they were in each phase of the process. And so, of course, across their y-axis, they have the date, so the discharge month, and then they have the percentage. So their SMM rate is not in rates per 10,000 like we're used to seeing, it's in percentages. And so what they showed and what you see in the red line is what is often called that median line. So with and actually here they're given a mean and not a median, but a lot of people, their middle line is their median. What they've shown is that pre-intervention, their SMM hemorrhage rate was 45.5% for non-Hispanic Black mothers. And they looked at this data between June and February pre-intervention, and the denominator was 121 individuals. Then in March of 2019, as she discussed in the summit, or at the summit, they presented data to the team. This is where she said she talked to her chair and said, you know what, I know that Texas Children sees itself as a champion hospital that does so many things so very well. But what we're finding is the data is not showing that for us. And the chair was very supportive in saying, come and present your data. And just in presenting their data at the meeting, disaggregated by race, ethnicity, this is at their quality meeting. After that, they initially and immediately, I should say pretty immediately, because it goes into the next couple of months, saw a change that then you see the decrease in the median, and then it goes across. And then you'll see between March 2019 and June 2020, this is post-intervention. And so this is also before they'd implemented too many other steps within their quality improvement initiative. But across March 2019 to June 2020, they implement other steps. And they look at their decrease in that rate went from 45.5% to 31.6%. So we see that drop. Now we go to the next slide. I'm going to just point out a couple of things about run charts, which is that to see a shift, to call something a shift, you need to see 6 or more data points above or below that median line. And then to see a trend, you need to see 5 or more points going upward or downward above or below that line as well. And then with your runs, there are, we won't go deep into runs, because with runs, it helps us to understand if you see a number of runs, either too many or too few, whether that means that that's part of one data system. If you have too few runs or too many runs, you may be seeing that your data is actually 2 different processes happening. But if you have too few runs, it's not enough to make a determination. But when we're looking at runs, there are, we have a link there actually for a training. There are some very specific metrics for how we could look at runs and how we can look at the rules related to runs as to what that means for your data. But starting with just looking at shifts and trends, it's good to look and understand whether or not you've seen an increase or a decrease, or you've seen a process lead to higher levels or higher rates or higher percentages or lower. But before you can actually call that a shift or a trend, you need to see 6 or more data points for a shift, 5 or more going up or down for a trend. And then there are those called astronomical data points, which are those data points that are far outside the normal process that can be identified. So you see them here. Yes, actually, and Dr. Iverson put it in the chat, these rules are based on math. Yes, these are probability based, with low likelihood of chance being the reason. So what he's saying there in that is that it's not due to chance that you've seen an increase, or not due to chance you've seen a decrease. These are probability based determinations of whether or not, when you see a difference in these numbers, whether or not that's a real difference. So you go to the next slide. We'll just quickly look at that same graphic again. And so you can see here where you've seen this shift happen, where she has 6 or more data points between March 2019 and June 2020 that are lower than the data points you saw prior to that, prior to the implementation. And so on your run charts, especially for your own members of your faculty and staff, when you want to post these kinds of things in visible places on your labor unit, you want to label very well where your initiatives have begun and what's happened. So you can mark even where a PDSA cycle may have occurred. Make sure you have your median line there and show really clearly across time, monthly, it could be weekly, however you want to display your data. But you definitely want to have, somewhere in the range of 20 or more so data points so that people can really see a run chart going in a particular direction. So we wanted to take a moment to just point out the really great example of a run chart that was published in Dr. Davidson's work. All right, we can go to the next slide. Dr. Iverson also makes a comment here where he says, for this chart, if you want to go back one, Claire, they were only able to claim the improvement on looking back and seeing enough values under the prior mean. Exactly. Yeah. All right, we'll go to the next slide. So here are some examples of a control chart with special cause variation, again, pointing out those astronomical points, trends, shifts, and whether or not those consecutive points are above or below your center line and what those things mean. We have some links on our webpage to help, that are videos to help everyone understand run chart, special cause variation, or common cause variation, and understanding whether or not the data that you're seeing when you're putting that on paper is actually saying that you're having an improvement or not. And that's really important for us to be able to communicate that to our teams as we're doing quality improvement work. All right, go to the next slide. We'll turn it over to Claire to do a wrap up. I know it's 1 minute after the hour, so we'll take sort of the 30-second version, Claire, if you want to pull out and point out the ones that you find are most important.
Okay. Next month, join us. We'll be talking about equity data dashboards. You can download, we just released our maternal equity bundle toolkit, which will take you through all the measures step by step, and a QI improvement toolkit, as well as this lovely poster that you can print out yourself that we did with Team Birth and aligns with the Team Birth Pinquin Prems, which is also on our website on our resource page. If you went to the summit or weren't able to make it, you can look at the slides and the handouts, and also claim your credits if you did attend through there. We're still also giving out Aftershock viewing links. So if you haven't seen it, definitely use this. Lots of resources. We have some events about Get Out the Lead and the impact of pregnancy and infancy in person, some AIM webinars. We will be emailing these all out. A note again about the Speak Up training for implicit and explicit bias. Definitely tell your teams about this, as well as the ambassador training. And I think that is all we will cover for now. Thank you all, and we will make sure to send out all those in an email as well.
Thank you all for joining. Any final questions, please don't hesitate to put them in the chat. We're happy to respond.